Friends, ladies and gentlemen, welcome to IAGS 2021. Today we are going to go to endoscopy live at Lotus Hospital. This particular case we are going to demonstrate when and how to do a banding of varices in a case of a chronic liver disease. We have right now a lady who suffered from the chronic liver disease with the repeated hematemesis. She have undergone already 2 episodes of banding. The last one was about 6 months ago. So our aim today is to demonstrate to you whether she has any residual varices, whether it merits any treatment. Before we do that, we presume she would require banding. So right now I have the apparatus. The banding kit comes with the 3 major components. I'll just show. This is a very important thing which will go into the access channel that is going to release the band. I'll tell you exactly when we perform. The next important thing is this particular barrel with the 6 bands, as you can come in the close up. So this is actually preloaded with 6 bands, so that will be released. So it will be applied at the end of the endoscopy and it will be released when it's required. And of course there is an additional equipment we'll be using, that is the pull catheter. Okay, if you have all the 3 and you have the patient who is having the indication, then we shall perform. Let's go for the procedure. So let's go to the procedure. So I'm going to do the diagnostic part to start with. As you can see, for every diagnostic endoscopy, the essential one for everybody is to know the importance of the cockpit drill. When I say cockpit drill, you just look at the equipment, they are all in good order by checking the suction is working. It instilling water to clean the lens, and also if you just press the inferior button, just place your hand on the inferior button, it is able to insufflate. So I am able to insufflate the stomach and the esophagus when it is required. So all this equipment status is checked, satisfied, and the patient has been consented if necessary for banding. So let's go for the diagnostic endoscopy. You can see here the important person in addition to me are 2 more. One just controlling the head end of the patient with the victory sign. She is holding the mouth guard, ensuring the patient is having a nasal oxygen. And because of the COVID, we have taken all the precautions to the maximum by protecting ourselves and also taking care of the patient's test for the COVID status also confirmed, and she is COVID negative. So let's go to the procedure. I'll just place the tip of the endoscopy on the patient's mouth. As you can see, the immediate surprise finding you will see is an upside down view with a soft palate. You treat the monitor like a clock. So what you see at 6 o'clock is soft palate, and of course the tongue, which you presume it should be in the 6, actually is the upside down view. So once you go there, you watch my left hand. I'm just bringing the big wheel towards me, so that will take the scope little deeper into the postcricoid region. Then you just slide under vision and enter the esophagus and gradually go down. What you see is few dilated varices, and usually it is just a grade 1, and here there is only 1 grade 2 varices. How you grade the varices? Grade 1, 2, 3 and of course 4 is depending upon the size, is not the length. Let us come to it in a minute. Just let me proceed beyond the OG junction. How to enter the OG junction? One of the trick I usually admit, look at my right hand. I do a little what I call an anti-clockwise twist, torque like that. So that will keep the slide much more easier, and you dive right into the what I call the body of the stomach. If you walk towards in the monitor at 9 o'clock, you will be entering a puddle of fluid and fundus, which I don't want to do. If you dive towards the 3 o'clock, then you go in the right track. To do that, you watch my hand one more time closely. I just push the scope 5 centimeter at a time. At the same time, little torque, not too much, so that I am going to go right and to the up. So just go down to the right, big wheel slightly towards me, just a little bit, sedate 1 more milligram midazolam. Just keep torquing and big wheel towards me like that, like this. Water ready. So what I see is pylor. So once you keep doing, right side torque, big wheel towards me, then push the scope 5 centimeter at a time. You bring the pylorus back at the right center of the monitor like this. Once it's in the sight in the center, it will be very easy to enter provided your scope tip is straight like that. Okay, then what you see here is the duodenal bulb, and it is usually featureless, no rugal folds. Then what you see right in front of you is actually the anterior wall. Then I just take the small wheel little away from me. I see how I am standing also. So as I pull the scope and turn the big wheel towards me and the small wheel away from me, I'll be just going right deep into the second part, what I call paradoxically I'll be diving in. And I was looking at the patient like that. Now I am showing my back to the patient. In other words, I turn myself to the right in order to enter deep into the second part. Then slowly I turn back looking at the patient again. As you can see, slowly the scope also will fall back into the pylorus, as you can see. Then what I do is a little trick. You can see there are a lot of bile. If you have a cymaticon, you can also put it there, or just put some, and then see. One of the important things you have to watch for is a patient who had a known varices been treated adequately is whether she is having any ectopic varices. The first place you have to see is whether it is in the fundus or in the antrum or in the duodenum. As you can see, I am bringing the big wheel near completely towards me. So I see the first, what I see, a stretch, a band like stretch, which is the incisura along the lesser curvature, stretching from about 8 to 2 o'clock position. Then you can see the whole body. Then I just go like that. You can see there are tiny varices there, but nothing significant in the fundal region. And what you see striking is the congestive gastropathy. Let me just deflate, because you ought to do anyhow. I want to demonstrate a banding. So for that I just deflate the stomach. I'll just give a little more water. You watch in the monitor. Just to hold the scope, put water. You keep watching at 6 o'clock. If you see the picture, what do you see? A congestive portal gastropathy, very important thing. Okay. I'm just going to use the irrigation pump just to demonstrate what we call an importance of the underwater examination. So as you can see here we have a system wherein we can push plenty of water to irrigate. So it helps you to see, just dive underneath the water, have a look at this area. And this is not a gastritis. This is one where you should not do a biopsy, because the patient has a coagulopathy. This is a venous congestive gastropathy or portal gastropathy, and that has to be recognized. It has a very different characteristics. So you have to be very careful not to do biopsy. Recognize he has a significant portal gastropathy, mainly in the proximal stomach. So I'll just deflate, because I just want to demonstrate to you the principles of banding in this case. Even though she has only one varices, it's worthwhile demonstrating to you. Let me just come back. And especially when you suck, don't suck directly on the varices. That is the one thing. What is a sleeping tiger, you will be just waking it up. So don't do that mistake. You should be very careful, because I wanted to demonstrate the importance of the congestive gastropathy. That's why I put some water inside. Otherwise this is not the required practice. I'll just suck as much as possible. And all these patients ideally should have been given ondansetron, just to ensure they don't retch during the procedure. See, I am just coming. If you watch here, from the incisors around 38, you can see at least one varices right at the vaginal junction is about 2nd degree. So I am just going to do the banding only for that purpose. Okay. So I'll just to do the banding, because otherwise yes, only we can see one more additional thing is we can see scarring. All these areas were around 10 o'clock here and here around 7 o'clock, like a ridge like things. All this is a very typical picture of what I call a multiple sittings. He had the banding and all those areas have settled with the scarring. Occasionally one of these areas, if they bleed, they might require not banding but a sclerotherapy, either in the cetrol or sodium tetrahydrogen sulfate, or sometimes even butyl cyanoacrylate. See, you can see at 3 o'clock there is another scarring, nicely demonstrated. You can see the pale white scarring tissue. So these are the areas saying that we had banding done several months or years ago. So that's the way. Let us just come out. I'll just show the assembly, how it is done. Give one. So what I do is, here you can see I am holding the scope. This is the access channel. So in this access channel, each assembly differs, but you have to have this release handle fixed nicely, snugly into the access channel or the biopsy channel. And so now you have a big wheel, small wheel, and the release wheel, or what I call a red wheel, and it has to be on this side, because don't have it like this, a simple mistake. So it should be economically friendly, so it should fall, and also it should be nice. If you want to stop it also, it's good, so that you don't get dislodged. Now you come closer, you can watch, it is something like this full catheter is having something like a hook. So the purpose is, you just pass it through a small hole in the release handle, and it will just take it right through the access channel, which is about 2.8 mm in diameter. On this pull catheter, in a matter of few seconds, it will start appearing at the end of the scope. So then what you do is, you have your strap ready with this thread, which is having the preloaded band. So she is going to hook it like this. So what I do is, I hold it here. So both of us are controlling ourselves, so the scope is not dropped. Everything is done like a clockwork. Then I start pulling the full catheter. This thread along with the barrel is coming closer and closer to the tip of the endoscopy, as you can rightly see. And there are two different types of bands available, like one with a single thread and another with a double thread. There was a lot of argument which is better, but I think one has to be careful, and you discuss with the persons, the manufacturers, ensure it doesn't cause any damage to the bending section of the scope. Now if you watch, come closely to me, she is also helping me to show the light. You see a small groove in the release handle. You just, in this thread at the end, there is a knot usually provided, thanks to the Sally. This is by the Sally. You just put it here, dock it in the groove and leave it there, and when you just rotate this clockwise like this, so what happens, you can see I am slowly just shortening, and this barrel will be snugly fitting into this 9.2 millimeter diameter scope. Now you can see, even in the endoscopy view, what you have, a panoramic vision is now becoming like a tunnel vision. So I just turn this red wheel a little bit more, so that the thread is taut and brought around the place where the access channel goes. That is 7 o'clock in Olympus. If it is in the pendex, it will be a 5 o'clock. In other words, in the bottom half of the screen only, the thread has to come and it should be taut. The next important thing is to make sure this barrel is not accidentally detached. So for that, we put a small tape. These are all not described in the book, but it is a good practice. The second thing is, once you attach this, what happens to the scope, you can see the diameter of 9.2 becomes 10.5, something like that. And also it is not user friendly. The patient had an endoscopy just now. She may not like a bigger scope now. So you have to do a lot of motivation. For that, patient has to be motivated. Patient has to have what we call a nice flexed head, like the Japanese position, and it has to be lubricated. We actually use the lubrication only for that purpose. And the next important thing I will tell for this purpose is to check the success of the band depends upon a good suction. To ensure it is suction, I will just see whether it is working. So I am not going to put all the bands. It is only for the demonstration. I told you I am going to apply only one or the maximum two bands. So I am going to demonstrate to you couple of bands here. So what she is doing is, imagine that is the varices she is keeping, and I am just putting the suction on. So you can put the suction on. The suction is there, but it is not adequate. Okay, so keep it. So we will just look into it in a minute. Keep sucking so that it is ballooning inside slowly, filling the barrel. I am just waiting for it to get inside so that I can catch it. If I release this wheel, see, clockwise like that, with the keeping the suction on, very important thing is, then one of the band will be released. You wait, even after releasing the band, I will not release the suction hand in my, I slowly, only after 10 more seconds I will release it. She will release the hand, and this is what happened. So the same thing we ensure it will happen. But I can say from the experience, the suction is not adequate for the first one, and we will improve the suction. We will put one more band in her next finger. So let's see. Now I am going to, we have improved the suction by just checking the suction pressure, because suction is a success for the banding. Now she is going to offer her other finger. I am going to just put one more, just look at the internal view, endoscopy view. Now I am sucking how it should, just quickly it comes. See, for example, it should come like this, little bit faster than even this one. If you have a better the suction, better. Now it is going to, what we look for is, here is something like a white out, but in her case it should be like a red out. It will be totally red, out of focus. I presume the whole glove or whole varice is now filling the barrel. Now I can turn this wheel, and I will see what I call is a sense of giving way after turning about half a circle like that. Once I have done that, you see I am maintaining the suction for 10 more seconds for two things to settle down. Then slowly I take my hand, and she will also have another band applied. So by doing that, I am confirming that it is working fine. Now we can do, this is called a dry run. Next thing, if you watch the monitor, because I released two bands, now because of the transparent glass, I have a little better view. So I made my life easy by releasing the unwanted bands earlier. So let's go to the procedure. As I said, this is going to be a little tricky. So you need somebody experienced enough to bend this head towards me so that it is comfortable. And as you can see, I am going to the post-cricoid region. Once you go there, ask the patient to take a swallow. Yes, see, it has gone. This is the most challenging one to start with. So I can tell you the tips. One is that intubation is going to be challenging. The next thing is, the first time banding is easy one. This is one of the easiest procedure I can teach anybody. But this is the third or fourth time I think we are doing this lady, and also it is a one small varices. So smaller the varices, and if it is not a primary one, a secondary varices or residual varices with a lot of fibrosis, the chances of not able to band is very high. So you should be very patient. Okay, I just go down slowly and ensure there is no fluid. Go there. So I'll just go right here at the OG junction, and this is the only area I can see. See, this is the one I am going to band. So what I am doing is right at the OG junction. What you see now, you don't see anything, just red out. So with a leap of faith, I just turn the wheel. I'll just put one is enough, because I am not going to put any more. So I am just putting one more. Nothing will happen. There is no harm if you have two bands also applied. Then slowly release the hand and just instill water and see what happens. You created something like a grape. See, this is what happens. So every time when you apply, I can even put one more here. There is one more on this area also, but there is actually no need. As you can see, they are all grade 1. In other words, grade 1 varices they are so small, can be easily missed by the beginner, missing varices. Whereas grade 2 are slightly bigger, about less than 5 millimeter in diameter. Grade 3, grade 4. The 4 is so big, nobody can miss it, and they will be kissing each other. So this is a grading, because 3 or 4 only we normally band. Here for demonstration I banded what it looked like a grade 2 right at the OG junction. Then I just aspirate, and because it's only demonstration, we'll just leave her well alone, because we don't want to do any more harm for her. Okay. And in case you are not able to do, as patient is not suitable and she is coming back, and we have other one, that is what we call the butyl cyanoacrylate, available as 0.5 and 1 ml, and also for that you need a special injection needle, which is slightly bigger needle, in the sense it is a 21 gauge. So the gauge of the needle, the length of the needle, and the fluid, the dosage, everything has to be done. And a glue injection, unlike a banding, is a more advanced procedure, and we see it in a different module. Thank you very much.